Yes, thank you very much. And I'll start sharing my screen here. But yeah, so in the United States, and I'll be using the term ganaxolone today, just on the scientific side, we kind of stay with the scientific chemical name, but the branded name in the United States is going to be Ztalmy, and that's Ztalmy. So if you have questions, and you also have the availability to look up Ztalmy and get more information there as well. But let me share the screen today, and I'll start off with just a quick introduction to Marinus. If you're not familiar with Marinus as a company, it's been around for over a decade. The company actually was founded as a research and development organization and really revolved around this ganaxolone molecule and really trying to develop it, make sure it became available for treatment and trying to find the exact match and the perfect match for where does this medication fit in terms of its function and what kind of disease states may it have a positive benefit on is really what the company focused on for a number of years, trying to find that right kind of balance. At the core of Marinus's mission is sort of a commitment to taking this ganaxolone molecule and bringing its potential benefits to patients and their families. And we do that through, really continuing to try to innovate. So even though we are happy to have information around ganaxolone and the CDKL5 population, the Marinus is really committed to bringing ganaxolone to patients, but we know that the key to doing that is actually working with communities like the CDKL5 patient population and their caregivers, and so we definitely appreciate all the help throughout the clinical development, the clinical trial that we'll be talking about today, and really just the advocacy now that's still going on about the awareness of ganaxolone. So thank you for allowing us to present today. If you have not heard about ganaxolone before, I want to go into a little bit of the background of ganaxolone in terms of what it is and a little bit in terms of how we think it actually works in terms of controlling epilepsy. So ganaxolone is actually very interesting because it falls into a new class of seizure medications called neuroactive steroids. Neuroactive steroids have actually been around for many years because they're naturally occurring in the body. Your brain naturally makes some of these neuroactive steroids, such as allopregnanolone. What we have learned is allopregnanolone, because it is produced internally, has no kind of oral bioavailability. So if you want to give an individual allopregnanolone, you actually have to give it to them IV because you cannot absorb it through the digestive tract. The unique thing that we found by adding a 3-beta methyl group, this is little kind of group that's highlighted by the circle on the diagram here. This actually does a couple of things to the allopregnanolone molecule to actually make it become ganaxolone. It does create a level of oral bioavailability. Now we have the ability to give you an oral dose of this and you are able to absorb it. It also increases the stability of the molecule. So with allopregnanolone, because it is a compound that is taken and created in the body, it also can sort of go backwards and actually go back into some of the normal kind of classical hormones, steroid, like progesterone, and have kind of some of those classic hormone-based steroid side effects. So one of the nice things about ganaxolone is we do not see that back conversion. And because of its mechanism that we'll talk about in just the next slide, we see a very different side effect profile than you might think of with classic sort of steroid treatments like your prednisones, prednisones, or even things that increase steroid activity like your ACTH. We do know that in early preclinical models, and we talked about early R&D development with Marinus, a wide spectrum of anti-seizure activity in these preclinical models. So we're very excited to see, all right, what can actually ganaxolone do in patients and see if that holds true going from these preclinical models all the way over to patient care. But the first step is really understanding how does ganaxolone work. So with all seizure medicines, we have limitations because we know how seizure medicines work kind of in a lab setting. It's hard to really know exactly how they're working in a human-based setting. So the proposed mechanism of action is through binding on GABA A receptors. And it has an effect on these GABA A receptors is by what's called positive allosteric modulation. And that's a very long term to mean that it just enhances how the channel works. So these GABA A receptors are sensitive to binding by a chemical called GABA, and it's an inhibitory neurotransmitter. It tends to be the off signal in the central nervous system. When the GABA binds to these GABA A receptors, it opens it up and it allows chloride channels to open and chloride ions to flow through. As that chloride ion flows through, it actually makes the cell more calm and harder to discharge. So ultimately, this off signal is accomplished by that influx of chloride ions into the cell. We know that classically, benzodiazepines do this as well. Benzodiazepines also bind to the GABA A receptor and allow for an increase in chloride ions. But there are two differences that are very important when looking at classic medications such as benzodiazepines that modulate the GABA A receptor and ganaxolone. One is ganaxolone has a separate binding site, so it's not competitive with benzodiazepines in terms of binding to the GABA A receptor. Secondly, it's very important to understand that it binds to both synaptic GABA A receptors. So these are receptors that are right in between the end of one axon and the receptor of the next neuron, but also what we call extrasynaptic GABA A receptors. And these extrasynaptic GABA A receptors are not targeted by benzodiazepines. So we're able to kind of increase this off signaling, or what we call inhibitory tone, by manipulating and enhancing the response to GABA in both synaptic receptors, but also extrasynaptic receptors. So what does this mean for patients, and why did we decide to study this in patients? Well, we wanted to prove that this preclinical model and this understood mechanism of action of this medication would have a clinical impact on seizure control. So I want to talk to you today about our Marigold study. This is our phase 3 kind of global trial, specifically in patients with CDKL5 deficiency disorder. As mentioned, this was global, not just in the US, double-blind, but a placebo-controlled trial with ganaxolone, using oral ganaxolone in patients with confirmed CDKL5 deficiency disorder. Our primary outcome, which is what we'll focus on today for the sake of time, is really looking at the impact in terms of a 28-day measure of what we refer to as major motor seizures. When we say major motor seizures, we're talking about tonic seizures, clonic seizures, tonic-clonic seizures, absences, and even focal to secondarily generalized or focal to bilateral seizures as well. So seizures that are kind of easy to track, seizures that have a significant impact on the patients, and the seizures that tend to be the predominant seizure type in the CDKL5 patient population. We did have some additional key secondary endpoints. 50% responder rates is one that we looked at. And we also looked at some global impression data, both from caregivers and providers. Now, who was able to get into this study? Well, we have the key enrollment criteria here. We looked for patients between 2 and 21 years of age. We actually enrolled patients between 2 and 19 years of age. They did have to have a confirmed CDKL5 gene variant. We had a baseline entry criteria before screening of at least 16 of these major motor seizures per month as an enrollment criteria, and we'll go through that process on the next slide. They could be on up to 4 other seizure medications, but had to have at least failed 2 other seizure medications in the past. Because of the difference in treatment, we did exclude any patients that were kind of with West syndrome, with hypsarrhythmia, or predominant infantile spasms, because that would be sort of a different treatment approach than what we were looking for in this initial study with ganaxolone. We also did exclude ACTH or other systemic steroids, just because we wanted to look and make sure we had a clear differentiation in terms of adverse event profiles between what would be seizure-related and really defining what we would see with these steroid-related compared to what we'd be seeing with these neuroactive steroids. So as we looked at the study, you'll see on the far left here, this historical seizure baseline. And that's when we actually had patients before they were even screened for the study, were recording their seizure frequency. And this is where they had to have this greater than 16 major motor seizures per 4 weeks, basically 28 days, over a 2-month period of time. So we really wanted to make sure that there was consistency in terms of the seizure burden, so we would have an ability to see a higher sensitivity of, is there an effect of ganaxolone in this patient population? If patients met that criteria and met the other screening criteria, they were able to enter this baseline period of time where we did, again, a tracking of their seizure frequency before they were randomized in a 1-to-1 ratio to either ganaxolone treatment or to the placebo arm. Those that were randomized to ganaxolone were treated based on weight. So patients that were up to 28 kilograms were titrated up over a 4-week titration period to 63 milligrams per kilogram of weight per day. And that was divided into 3 times a day dosing. And patients that were 28 kilograms or greater They were done on a fixed dosing starting at 150 milligrams per dose and titrating up to an 1800 milligram or 600 milligrams 3 times a day gold dose. Like I mentioned, that titration went over 4 weeks. The titration was done in essentially 25% increments. So 6 milligrams per dose, 11 milligrams per dose, 16 milligrams per dose, and up to 21 milligrams per dose. Or as I mentioned, a fixed dose at 150, 300, 450, and 600 for the group over 28 kilos. They were then maintained on that dose for 13 weeks. And then at the end of this overall 17-week treatment phase, patients were given the opportunity to enter an open label extension phase, which initially was initiated through a blinded titration, not to unblind them from whether they were on the placebo or treatment group initially. And then they went into the open label phase where they knew all of these patients were currently on treatment. A little look at the kind of demographics of this patient population here to kind of see how that may compare to patients that you're caring for or patients that are under your care. These demographics shows ages of 7 on average for the placebo and 5 for the ganaxolone group. You can see the ranges here. This is interquartile ranges from Q1 to Q3, 4 to 11, and 3 to 10. So similar ranges over there. As you might expect, we had a predominance of females involved in the trial, essentially about a 4-to-1 ratio, female to male enrollment. We look at on here also characteristics of the seizures that they're bringing to the table. So we look at their baseline major motor seizure frequency per 28 days. We see in the placebo group, it was an average of 49.2 seizures in that 28-day period. Ganaxolone group was a little bit higher at 54 seizures in that 28-day period. These patients were overall very refractory patients, a mean number of prior seizures, roughly around 7, so 6.8 in the placebo group and 7.8 in the ganaxolone group, averaging out to be about 7.3. And the number of other medications they were currently on was a little bit over 2, so 2.2 in the placebo group and 2.6 in the ganaxolone group. We looked at other medications of what they were taking, and here we list the medications that were being taken by more than 20% of the patient population in either placebo or the ganaxolone group, and they were actually the same 4 medications. This was valproate, valproic acid, levetiracetam, clobazam, and vigabatrin in this patient population. So we'll look at our primary endpoint, which we talked about percent reduction in major motor seizure frequency. And what we see demonstrated here was ganaxolone was able to reduce seizure frequency by 31% compared to baseline, compared to about 7% with the placebo arm. Now we look at this number and we say, gosh, 31% is maybe not necessarily a very high number. And we want to look and see that the thing in looking at these studies is what was the difference from placebo? And so how we looked at whether this was a significant response was not just the raw number, but also the difference from placebo. And what we see with this relatively low placebo response compared to other epilepsy studies that are out there and kind of more focal onset type seizure disorders is we saw a difference in the means of these of around 27%, which gave us a p-value that was significant of 0.0036. So we see that a 31% reduction is significant, especially when compared to the placebo response in this patient population. Now, along with efficacy, we always want to talk about safety. And so here we also look at treatment emergent adverse events. And if you're not familiar with kind of how we define a treatment emergent adverse event, is basically any unexpected event that occurs during a clinical trial, whether it's related to the medication or not. That's a different aspect because we want to know what may be related. And so we do record all of these treatment emergent adverse events, and then later on try to see if there's any trends that are associated with a treatment. And we do that by comparing it to placebo. So you can see overall in the treatment emergent adverse event profile here, a very similar number between placebo and ganaxolone. We do see kind of an increased risk of somnolence that really stands out here. 36% of patients experience somnolence on the ganaxolone treatment arm versus about 16% in the placebo arm. But we saw a higher incidence also in pyrexia or fever, as well as seizure being a little bit similar between the two, a little higher in the placebo arm. And then things like vomiting, upper respiratory tract infections, and even salivary hypersecretion, a little bit higher maybe in the ganaxolone group and some of those versus placebo. The other thing when we look at treatment emergent adverse events, we want to see what was the impact and how severe were they. So we look at severity. One category we look at is serious treatment emergent adverse events. And those are adverse events that cause things like hospitalization or prolonging of hospitalization, which would be especially kind of the more common one that you would see in this specific patient population. There are other adverse events that can fall into serious adverse events as well. And you see a similar number between the two of 6 patients and 5 patients in the ganaxolone versus placebo groups here. We also looked at how much of these adverse events lead to drug discontinuation and falling out of the study, or actually individuals that maybe needed a dose reduction or a pause in dosing before a resuming of the treatment somewhat later on. And we see here 2 patients in the ganaxolone study did have to discontinue the study due to adverse events compared to 4 in the placebo arm. And we see a higher number of patients that actually had a dose interruption or a dose reduction in the ganaxolone group here, about 22% compared to 16% in the placebo arm. Fortunately, in this study of 101 patients, we saw no treatment emergent adverse events leading to death in any of the placebo group or in the active ganaxolone treatment group. So overall, I just want to kind of bring a conclusion to this as ganaxolone, again, is a neuroactive steroid. This is a new type of seizure medication that providers that you may be interacting with may not be aware of, maybe not be something they're familiar with. So there may be some education that we as a company need to provide to these educators, or that you, now that you're a little more educated about it, can provide it as well. It is a positive allosteric modulator, which means it's enhancing the response of this GABA A receptor to the binding of GABA. And it does this both at synaptic and extrasynaptic GABA A receptors, which is really the differentiator in terms of the mechanism of action compared to other medications that also work on the benzodiazepine, the GABA A receptors such as benzodiazepines. We do know it's shown broad efficacy in preclinical seizure models. And we brought that actually to clinical trials finally in the Marigold phase 3 study. We looked at oral ganaxolone in children and young adults. Again, looked at 2 to 19 actually enrolled in the study. And what we found is their 28-day frequency of major motor seizures were significantly reduced compared to placebo as a primary outcome measure in this clinical trial. Again, 31% reduction compared to 7% in placebo. Overall, the reports of the treatment emergent adverse events, including serious treatment emergent adverse events, and also discontinuations or disruptions of treatment, were overall fairly similar between the ganaxolone group and the placebo group. We did want to highlight the more frequent treatment emergent adverse events seen in the ganaxolone group, the most frequent being somnolence, like we mentioned, 36% versus roughly 16% ganaxolone versus placebo, but also pyrexia, upper respiratory tract infection was there. Very excitingly, we are able to announce that we received approval by the FDA for distribution in the United States in March of this year. We have recently received our DEA scheduling, so we will be a Schedule 5 medication. We received that just earlier this month on June 1st. It was like it was meant to be to have that to move forward. And we anticipate commercial availability of the product likely sometime in August in the United States. So we are very excited to have completed this clinical trial and now actually have approval from the FDA, scheduling from the DEA for commercialization in the United States. Additionally, I do want to mention that the full results of the Marigold study that I kind of covered the highlights with you today are actually available and through a publication back in May in Lancet Neurology. So you'll see the full Marigold study as well as some additional addendum type information about more breakdown of different study features that you can find. So if there's more interest in learning more about the Marigold study that we don't have time to cover here today, I would reference you to the Lancet Neurology article where you can get some additional information. Again, that was May of this year. So that will be the conclusion of my presentation. I'll end the slideshow here and see if anyone has any other questions.
Thank you, Dr. Flatt, for that presentation. It was really wonderful. I know there was a few Canadian families in the study, so
Right.
so that's great. So you mentioned that it's available only in the U.S. market right now?
So right now, it's not even commercially available yet in the U.S. market. It is only going to be available. We're anticipating sometime in August, based on just having to wait for our DEA scheduling There were some changes in terms of getting those final labels all printed and shipped and on bottles and all that stuff. So there's more logistical things in terms of being able to get it out into the U.S. market. And then obviously we are looking at then trying to expand its availability beyond the U.S. market.